I was thinking about how we usually visualize the human body. If I say musculoskeletal system, or MSK for short,
Right.
most people immediately picture that plastic skeleton hanging in the back of a high school biology classroom.
Oh, yeah. The coat hanger.
Exactly. It's
Yeah.
dry, it's rigid, and frankly, it's dead. It's just scaffolding.
That is the classic image. It feels very static,
Yeah.
structural.
But looking at the research we've pulled for this deep dive, that static image is just dead wrong. If you're actually working in healthcare, the MSK system isn't just a framework, it's the engine.
And assessing it isn't just ticking a box. It's like a detective story.
That's the perfect way to frame it. It is a detective story because how a person moves or, doesn't move tells you how they live.
It reveals their independence, their pain, and sometimes it's the first alarm bell for something going wrong in the brain or even the heart.
So that is our mission today. We are taking the musculoskeletal assessment, which, let's be honest, can feel like a boring checklist of lift this, push that, and we are turning it into a vital clinical skill. We're going to look at the what, the how, and specifically the critical why behind every touch and observation.
But we have a serious roadmap ahead. We're going to start with a general survey, what you spot before you even say hello.
Then the massive link between bones and the brain, the neuro-MSK connection.
Yep. We've got the 3 pillars of assessment to organize our thinking, and we are going to spend some real time on the 6 Ps, which is basically the survival guide for saving a limb.
Plus, we can't ignore the safety side patient education and those easy-to-miss medication risks.
Absolutely. So let's get into the detective work.
The source material makes this really distinct point right out of the gate. The assessment does not begin when you touch the patient.
No,
It begins the second your eyes land on them.
this is the general survey. You are gathering data immediately. Think about walking into a patient's room. Before you say hello, you're looking for distress.
And distress isn't always obvious, is it? It's not always someone screaming.
In an MSK context, it's often silent. It's all about body language.
So what am I looking for?
Look at their face. Are they grimacing every time they shift their weight? Are they guarding?
Okay, define guarding for us in this context, because I'm picturing a security guard, and I know that's not what we're talking about here.
It's a protective mechanism. So let's say a patient is sitting on the edge of the bed. If they're leaning heavily to the left, using their arm to prop themselves up so their right hip doesn't take any weight.
Ah, okay.
They are guarding that right hip. They're physically shielding a painful area from any pressure. That tells you where the problem is before you've asked a single question.
That makes a lot of sense. The sources also mention looking at hygiene and grooming, which, at first felt a bit judgmental.
I get that, but it's purely functional.
Hmm.
If a patient comes in with uncombed hair or a shirt that's buttoned wrong, you have to ask why.
It might not just be a choice.
It's often because they physically can't reach their arms above their head to comb their hair, or their fingers are too stiff from arthritis to manage buttons.
So a messy shirt isn't a fashion statement. It's a range of motion deficit staring you in the face.
Precisely. It's a functional limitation that gives you a baseline for their daily life.
Now, I want to connect this to vital signs. We usually keep vitals and skeleton in separate mental boxes.
But you can't. You can't separate them. Pain is the bridge. Pain is the primary symptom of musculoskeletal injury, and the body reacts to acute pain with a stress response.
So the fight or flight kicks in.
In a way, yes. If someone has a fracture or a torn muscle, you're going to see the numbers climb. Respiratory rate goes up.
Blood pressure spikes.
Blood pressure, heart rate, all of it increases. If you see a patient who is grimacing, guarding an arm, and their heart rate is 110, your detective work is already pointing to an acute MSK issue.
Okay, so we've observed. Now we sit down to talk. We're taking the history. And obviously we ask, where does it hurt?
Yeah.
But we need to dig deeper.
Much deeper. We need to know about structural diagnoses, things like osteoporosis or arthritis. But the one that really matters for safety is diabetes.
Because of the neuropathy risk.
Yes. If they have diabetic neuropathy, they might not feel the pain of an injury as intensely, which complicates your whole assessment. But beyond diagnoses, we have to look at their medication list.
This part fascinated me. I don't usually think of standard drugs as causing muscle pain, but the sources flag 2 very common ones.
They are incredibly common. First, you have certain antibiotics, specifically the fluoroquinolones like Lidocaine.
Okay.
And second, you have statins, which millions and millions of people take for high cholesterol.
And these can actually hurt your muscles.
They can cause myalgia, which is just the clinical term for muscle pain. Statins in particular are notorious for this. Patients will complain of this new aching muscle soreness.
So if a patient says, my legs are just aching, and you see they started a statin last week, that's a dot you have to connect.
It's a classic red herring that you have to catch.
Yeah.
And speaking of muscle pain, we have to talk about lifestyle. It's great when patients exercise, but the sources warn about that weekend warrior phenomenon.
The person who does nothing all week and then runs a marathon on Saturday.
Or decides to do an intense CrossFit session with zero training. If someone does that and comes in with severe muscle pain and weakness, we have to worry about a condition called rhabdomyolysis.
That's a heavy word. Break that down for us.
Rhabdo basically means the breakdown of damaged skeletal muscle. The muscle tissue literally breaks down and releases its fibers into the bloodstream.
And that's bad for the...
It can be incredibly toxic to the kidneys. So recent excessive exercise isn't just a fun fact, it's a risk factor for a medical emergency.
Which brings us to a huge theme in this research, the neuro-MSK link. The idea that muscles don't move on their own, they need a driver.
Think of the nerves as the software and the muscles as the hardware. If the software crashes, the hardware is useless. You can't view the MSK system in isolation.
So a lot of muscle problems are actually neurological diseases in disguise.
That's it, exactly. The sources list some heavy hitters here. Stroke, multiple sclerosis, cerebral palsy.
Right. So if you're assessing a patient with a stroke history and their arm is weak, it's not because the muscle itself is broken.
It's because the signal from the brain isn't getting there. So when we assess strength, we are really testing the integrity of that entire connection. It's a two-system check.
I like that. So we've done our history, we understand the risks. Now we start the physical inspection. The sources use a framework called the 3 pillars.
Right. It helps keep you organized.
What are our pillars?
Pillar 1 is range of motion.
Okay, wrong.
Pillar 2 is muscle strength and tone. And Pillar 3 is joint and muscle condition.
Let's tackle pillar 1, range of motion. This seems pretty binary at first. Can you move it or can you not?
It's a bit more nuanced. We divide it into active and passive. Active ROM is when I say lift your arm over your head, and you do it. You're using your own muscles.
And passive.
Passive is when you can't do it, so I hold your arm and I move the joint for you.
And that tells you something different.
A huge difference. If a patient can't move the arm actively, but the joint moves fine passively, that tells us the joint is okay. The problem is with the muscle or the nerve firing it.
That's a crucial distinction. Okay, pillar 2, muscle strength and tone. We're looking for extremes here.
We're looking for what feels wrong. On one end, you have hypertonicity. This is high tone. The muscle feels tight, spastic, maybe even rigid.
You see that a lot in cerebral palsy or after certain strokes.
Exactly. And on the other end,
Hypotonicity.
low tone. The muscle is flaccid. The source uses a very specific, slightly gross adjective here, boggy.
Boggy. Yeah, that sticks with you, like a wet sponge.
Yeah, that's it. It feels soft and mushy because the muscle has atrophied. It's wasted away from lack of use. If you feel a boggy muscle, you know that limb hasn't been doing any work for a long time.
Visual inspection is also part of this. We're watching them move, watching their gait.
Gait analysis is fascinating. You're looking for the obvious limp, sure, but look at the feet. Are they picking them up or are they shuffling?
And shuffling is a specific red flag, isn't it?
It is. A shuffling gait where the feet barely leave the floor is a classic sign of Parkinson's disease, and it's a huge fall risk.
And what about the spine? We're looking at their back alignment. There are 3 specific terms the sources highlight that we need to be able to identify.
Right. These are the spinal malformations. First, look at the upper back, the thoracic spine. If there's an exaggerated outward curvature, the hunchback look, that is kyphosis.
Which we see mostly in older adults.
Yes, often due to osteoporosis. Then look at the lower back, the lumbar region. If it curves inward too much sway back, that is lordosis.
Like you see in pregnant women sometimes.
Exactly. The center of gravity shifts forward, so the spine compensates. And finally, the one everyone remembers from middle school screenings, scoliosis.
The S-curve.
Right. It's a lateral sideways curvature. The spine should be a straight line down the middle. If it looks like an S or a C, that's scoliosis.
Okay, we've looked, we've listened, we've watched them walk. Now we have to get hands-on. We're moving to palpation.
This is where the rubber meets the road. You can't assess MSK without touching. And you have to differentiate between a full head-to-toe and a focused assessment.
If they came in for a sprained ankle, don't start poking their neck.
Correct. Focus on the injury. We are feeling for heat, which suggests inflammation or infection, tenderness. And we are feeling for something called crepitation.
The source describes this as palpable subcutaneous air, but then it gives the best description ever. Rice Krispies.
It is uncannily accurate. It feels like a crunching, crackling sensation under the skin. It happens when cartilage is worn away, bone grinding on bone, or if air has leaked into the tissue.
Once you feel that crunch, you never forget it.
Never.
Rice Krispies under the skin. Got it. Now let's test strength. The key concept here isn't about being strong, it's about symmetry.
Always symmetry. You must compare the left side to the right side simultaneously.
Why simultaneously? Why not check the left, then check the right?
Because your brain is so much better at detecting differences in real time. If you do the hand grasp test, squeeze my fingers, and you have them do both hands at once, you will instantly feel if the left grip is weaker than the right.
And that unilateral weakness on just one side, is a massive siren.
It's a stroke indicator. Until proven otherwise, new unilateral weakness is a neurological emergency.
And we do this with the feet too, right? The gas pedal tests.
Yes. Put your hands on the soles of their feet and ask them to push on the gas. Again, together. If one foot pushes hard and the other just drifts, you found a deficit.
This leads us to what I think is the most critical part of this entire deep dive. If you take away one thing, it should be this mnemonic. The 6 Ps of neurovascular assessment.
This is the gold standard. This is how you save a limb. If a patient have a cast, a crushing injury, or just had vascular surgery, you live and die by the 6 Ps.
This is checking if the blood and the nerves are still working in that limb. Let's run through them. P number 1, pain.
But not just, it hurts. We need to know if the pain is out of proportion to the injury. Is it a deep, unmanageable pain? That's a bad sign.
Number 2, pallor.
The color. If the limb is pale, white, or shiny, the blood isn't getting there. It's like a ghost limb.
Number 3, pulses.
Non-negotiable. If they have a broken leg, you must check the pulse below to break, the pedal pulse on the foot. No pulse means no blood flow. End of story.
Number 4, paralysis.
Can they move it, even if it hurts? Can they wiggle their toes? If they can't, the nerves are compromised.
Number 5, paresthesias. It's a mouthful, but what does it mean?
It means sensation issues, pins and needles, numbness, tingling. If a patient says their foot feels asleep, that is paresthesia. The nerve is being compressed.
And number 6, the spelling bee champion, poikilothermia.
Poikilothermia. It just means the limb has taken on the temperature of the room because it can't regulate itself. In practice, we're just feeling for coolness.
So if the good leg is warm and the injured leg is ice cold.
That's poikilothermia. So let's put it together. If you have a patient with a leg cast and that leg is pale, pulseless, and cold.
You don't put a warm blanket on it, you call the surgeon.
Immediately.
Yeah.
That is a medical emergency. You are losing that limb. That's why we obsess over these 6 Ps.
High stakes stuff. Okay, let's assume we've assessed them. They're stable, but they have an injury. We need to teach them how to handle it. We start with the Ricey method.
The classic protocol for acute injury. Rest, ice, compression, elevation.
It sounds simple, but there are safety traps here. Let's talk about ice.
Big safety traps. Never put an ice pack directly on the skin. You can cause frostbite or skin burns. Always, always put a towel or a washcloth between the ice and the patient.
And elevation. It's not just put your foot on a stool, is it?
No. Physics matters. To reduce swelling, the fluid has to drain back toward the heart. So the limb must be elevated above the level of the heart.
Otherwise, gravity can't help you.
Right. It's just sitting there.
Okay, that's a detail I definitely would have missed.
Yeah.
Now, what about painkillers? Patients are going to reach for the medicine cabinet?
They will, and we need to guide them. Usually it's NSAIDs or acetaminophen. They have different risks.
So if they are taking Tylenol, which is acetaminophen?
Watch the liver. If they have liver disease or drink a lot of alcohol, Tylenol can be dangerous, and you strictly cap it at 4 grams a day.
And if they are taking Motrin or ibuprofen?
Watch the kidneys and the stomach. Motrin can cause GI bleeds and stress the kidneys. If they have a history of ulcers, Motrin is off the table.
Okay, we've assessed, we've detected, we've taught, now we're leaving the room. But the job isn't done.
The post-assessment protocol. You never just walk out. First, safety. Are the bed rails up? Is the call bell right there, within reach?
Especially if we just found an MSK issue, they are now a fall risk.
Exactly. And finally, the golden rule of healthcare documentation. If you didn't write it down, it didn't happen.
So you need to record the strength, the ROM.
And specifically that the 6 Ps were negative. You need to prove that limb was pink, warm, and moving when you left that room.
It really brings it all back to that detective concept. We've gone from spotting a messy shirt to checking for pulses to prevent an amputation.
It connects all the dots. The MSK assessment is a window into the patient's overall stability. By checking the 6Ps, you're monitoring for limb-threatening circulation issues. By checking for that unilateral weakness, you are the frontline detector for a stroke.
It's so much more than just bones. And I want to circle back to something you mentioned earlier, the art of touch.
I think that's the provocative thought to leave everyone with.
Yeah.
We have amazing technology now. An MRI can show you a high-resolution picture of a muscle. It can show you the anatomy.
But an MRI can't feel.
It can't feel the bogginess.
Right.
Only your hands can feel the difference between a muscle that is firm and healthy and one that is boggy and atrophied. That sensation tells you a story about how long that patient has been immobile, how their nutrition is, how hard their recovery is going to be.
You can't get that from a scan. You have to get in there and do the work.
Exactly. So practice those bilateral comparisons until it becomes muscle memory. Your hands are your best diagnostic tool.
A powerful reminder to stay hands-on. That's a wrap for this deep dive into the musculoskeletal assessment. Thanks for learning with us.
Stay curious, everyone.